the oral oncolytics are currently dispensed, about half of them, I guess, by the specialty pharmacies, right? So what are these challenges in terms of the supply chain? Are the specialty pharmacies doing it right? Are they the best way to do this?
That's a hot topic.
That's why they pay me the big bucks to ask it.
So from my perspective, I have a dispensing program within my practice where we can dispense real time to our patients where we're allowed to. Certainly other patients need to go out to specialty pharmacy based on their insurance design. The manufacturer sometimes will drive where these new agents are procured. So a manufacturer may go with limited distribution and only allow a couple of specialty pharmacies to dispense a product. That limits access in my mind. We want our patients to be able to access these drugs from any point in their care. So from that perspective, I think you need to have broad distribution of these agents to really make sure patients have access.
Let me see if I'm hearing what you're saying. Broad distribution. It sounds to me as if that's almost an anathema to specialty pharmacies because there aren't general specialty pharmacies everywhere.
Correct. So, again, some patients are driven to specialty pharmacy by benefit design, but there are a lot of practices in the United States that have the ability to dispense oral agents to our patients, but we're limited by distribution practices or limited by insurance plans and coverage. And
you alluded to this. How do you determine, or how does anybody determine if a new oral oncolytic is going to go the specialty pharmacy route or not?
For our practice, we meet with the manufacturers up front when they have a new product being launched. Sometimes we're invited to advisory boards where we're getting firsthand knowledge of how the distribution model will work, and other times we're asked about distribution models. And our response always is to make sure that you make it available to everyone who has the ability to dispense the agent. From our standpoint, that's very important.
So you don't, am I hearing this right? You're not a big fan of specialty pharmacies for this stuff?
From my perspective, I believe that physicians that have dispensing programs should be able to dispense to all of their patients requiring an oral oncolytic. I say that as we're part of the oncology care model, which really makes us responsible for the cost of care and the coordination of care of our patients. So from my perspective, having control over that oral oncolytic, my physicians being able to monitor patients real time and adjust their therapies as needed, really improves outcome, reduces cost, and reduces waste.
Now there's another term of art out there, the limited distribution network. Is that distinct from specialty pharmacies? What is that?
Distinct from specialty in a sense. Limited distribution would mean that a manufacturer says, I'm only going to allow Express Scripts and Optum Rx to dispense these medications. We're not going to allow oncology supply to have access to give it to all the dispensing practices. We're going to limit who's available to distribute that drug.
Does that make sense?
Well, I mean, we see that every day now in our practices. So, for example,
I didn't ask if you saw it. I asked if it made sense.
If it makes sense. Well, that's a different, depends on who you're asking, right? So that's, I think it will make sense if we are doing it for the patient, because we're doing it to actually monitor the cost, monitor the benefits so they don't get excessive co-payments, for example, and that we're supporting the provider and the practices to actually get the medication.
But maybe I'm naive, or I certainly am naive in terms of how this all works. But if I don't have Express Scripts as part of my coverage, and it's only available with, and I don't mean to beat up on Express Scripts, we'll call it, I don't have pharmacoscripts, to make a generic word. I don't have access to that. Then how do I get this drug?
Well, the prescriber needs to send the prescription to that specialty pharmacy that has access to the medication, who can then get it to the patient.
And then there's got to be a
delay.
Paperwork.
There is a delay.
There's
So there is a
delay.
24, at minimum 48-hour or even longer delay for drugs that patients need, sometimes now. So this is the downside. This is a huge limiting.
And I would counter that with it can be weeks, not just days.
I think it's really days at best.
Yeah, days at best.
Days at best.
I would agree.
Right.
Look, ideally, I want to sit at my desk if I'm an MD. Say, I want this drug, and the drug pops up. Here it is, give it to the patient. Which brings up in-office dispensing as a generic concept. I mean, we're talking about specialty pharmacies and all kinds of barriers and paperwork. What about just, I got this drug in my office, I get it from the pharmacy company, the pharmacologic company, and I give it to my patients. I'll dispense it. Why not?
Well, that would be the fastest way to get drugs for patients.
What's the downside?
I guess potentially cost. Presumably insurance companies are able to make deals with some of the specialty pharmacies and get better deals than in-office dispensing. Although that is something that oncologists can compete with as well.